My talk is about the parathyroid and how to image the parathyroid. So just basically touching what the anatomy of parathyroid is. So it's four glands. It's situated in the posterolateral aspect. It could be two in the superior and two in the inferior poles of the thyroid. So these are the locations. This is the characteristic locations of the parathyroid. But there are variations, and rarely only 3 parathyroid can be present. Supernumerary up to 5%, and 20 to 30% of the people have 5th parathyroid. So 5th parathyroid is hyperfunctioning about 1 to 3% of the cases of hyperthyroidism. There are fewer in only 3%, and average size is 5 by 3 by 1, and they weigh about approximately 50 milligrams. Looking at primary hyperthyroidism, which is the normal indication for the scan, looking for whether there is solitary parathyroid adenoma, which accounts for 85%, and the others is 50%, which includes diffuse and multiple adenomas and parathyroid carcinomas, which is about 1 to 2%. Overall incidence is about 25 per 100,000 in UK population, and the classical symptomatic features were bone stones and abdominal groans. This was historical, but now because of examination and biochemical findings, these are rare entity. So how does it over or hypoactivate the gland? The glands produce and secrete parathyroid hormones. Synthesis and secretion is regulated by the calcium level in the blood. Failure to produce can produce hypo, and excessive production can produce hyperthyroidism, which leads to imbalance of calcium. That's why you need to monitor the calcium and parathyroid hormones. This is NIH criteria. What are the symptoms and what are the associated conditions? So it's a spectrum. So it could be from fatigue to memory loss, and it could be nephrolithiasis to hematuria and hypertension. So it's a variety of symptoms and associated conditions which you need to be aware of. And this is the NIH criteria for parathyroidectomy. So you need to have elevated serum calcium between 1 to 1.6 above normal, and history of episode of life-threatening hypercalcemia. Creatinine levels needs to be measured, and if they are reduced by 30%, then that's another criteria. Osteitis fibrosa cystica. These are the cystic lesions. They are in multi sites. It can involve the axial, mainly the appendicular skeleton, and it can happen in the axial skeleton as well. Reduced bone mass because of the overactivity of the gland and mobilizing the calcium. Neuromuscular symptoms, documented proximal weakness, atrophy, hyperreflexia, and gait disturbances. These are all indications. Imaging technique, these are the standard. Some centers they use, but in fact most of the centers, and we use a single MIBI scan at 2-time intervals. And most of the other centers, they use dual isotope subtraction scintigraphy using technetium MIBI and pertechnetate. The other methodology which is used is MIBI planar with SPECT, and the other is MIBI planar with SPECT CT. Ultrasound is also used in cases where there are problems, where they need to characterize whether the abnormal findings seen on scintigraphy can be localized by morphology. In our center, all these patients, if they are suspecting of adenomas or overactivity of a gland of unknown site, they have had their ultrasound initially, and they would have localized or suspicious of adenoma. And then they come down to us to localize the site exactly so that they can do the minimal invasive surgery. CT can add, but doing the SPECT CT, basically we have come out, but now we are starting to utilize contrast CT. Some of the centers in UK are utilizing that, and they have shown the significance of detection. MR, The only center where I've seen and I've worked was Oxford, where they used to do triple assessment. So the patients used to have MR, ultrasound, and maybe scan. Preoperative imaging approach is sonography and scintigraphy. That's standard in our center. And hybrid scintigraphy versus SPECT CT potentially very useful in giving extra dimension of information. So if you compare with SPECT and compare with SPECT CT, then it improves the specificity in detection. CT-MR not for routine, reserved for difficult cases, and PET-CT is an option. We have done few PET-CTs in patients where they cannot find and they think there is increased mitotic activity suggesting carcinoma somewhere which has not been picked up, and we do PET-CT, but it's not been useful from our experience. So dual isotope subtraction basically prior to 2000 was routinely used using MIBI and technetium. Significant proportion of parathyroid lesions were missed because either they were ectopic or they were not, they were too small to be characterized. Post 2010, dual phase scintigraphy using technetium, MIBI with SPECT CT, is being used. So for subtraction, the tracers that can be, it can be iodine, it can be technetium, and then you subtract at different intervals, and whatever is left behind suggests an adenoma. Dual time point relies on differential clearance of MIBI from parathyroid to thyroid, and we use 15 minutes image and 2 hours delayed images with SPECT CT. So this is basically using technetium and cyst-MIBI, and at basically subtraction used for localize focal uptake in the medial inferior part of the right lobe of the thyroid, and this is in keeping with an adenoma. This is what we use: early image thyroid plus parathyroid using cyst-MIBI, washout from thyroid and a delayed scan, and parathyroid uptake shows adenoma and confirms is parathyroid adenoma at 90 minutes scan. So using the planar and comparing with the SPECT first, so you just hardly see some uptake in the right lobe. This could be multinodular goiter, heterogeneous uptake with slight reduction in the left lobe. But if you do a MIP, it increases the sensitivity and specificity and localizes the focal uptake, suspicious of an adenoma. Looking at the SPECT, so it further improves your specificity in detection. Again, you look at these and you say maybe, maybe not, there is some uptake in the mediastinum. You do a CT and you see a large nodule in the aortopulmonary window, or just left to the left main bronchus. You fuse it and it shows activity, confirms that is an ectopic parathyroid gland. Ultrasound, how you see and what you see. This is the left or right, I don't know, it's not labeled. So this is the thyroid lobe. That's the nodule. Very characteristic, it's low hypoechoic, low signal, and then you've got the centrum, which is vascular, and then if you put Doppler on, look at the vascularity, it basically confirms. Reported sensitivity ranges from 72 to 89% in most of the literature. The limitations of doing the scan is false positive, which you should be aware of. It can include thyroid nodules, reactive nodes, sarcoid lymphoma, and false negative will include small adenomas and hyperplasia. So these are the drawbacks of, and you need to be aware when you are reporting that what could be the false positive and what could be the false negative. Just a comparison, Newman basically compares the SPECT CT with SPECT and shows sensitivity of 88% and specificity of 96% versus SPECT only 85 to 48%. Sharma et al. Looked at again comparing the SPECT and SPECT CT. SPECT CT showed 87% and 146 patients, and 85%, which was almost similar sensitivity. And Sarah et al. Surgical localization matched with imaging for SPECT CT in 100% cases versus 61% in SPECT CT. MR adenoma will have similar signal to nodes. It will be exactly like nodes, and issue with patient compliance because it is slight longer acquisition, and there will be basically respiratory movement artifact, and is quite cumbersome, and it's expensive and less clinically available. Not every place you have easy access because there is a referral pressure from the oncology and other clinicians. Similar sensitivity to ultrasound and MIBI, so that's why we resort to ultrasound and MIBI as our first line of investigation. So this is the T2 fat sat. This is the thyroid, and this shows a posteromedial nodule with a high signal, confirming that is a parathyroid adenoma. Looking at CT, it has, if you do an contrast enhanced CT, it enhances with the arterial flow, and you see a bright high density lesion. It could be in the posterior to the thyroid, it could be an ectopic site, and it peaks at the peak arterial, that is 20 seconds after injection of the contrast in the arterial phase, and it washes out. If you do a 60 seconds delay scan, so it washes out, that reflects the portovenous phase of the contrast. And when the contrast has washed out and you do a delayed scan, there is low attenuation, which basically suggests that that is a soft tissue, and whatever the enhancement was has washed out and shows the benignity of the nodule. So these are the SPECT CT, and this is the nodule. We use non-contrast CT using slice thickness of 0.25 millimeters. Shows fused image confirms in the nodule just lateral to the aorta in the superior mediastinum. This is what we are recently using: slice thickness of 0.25, effective dose of about 0.87. So these are the non-contrast. This is the arterial, shows enhancement similar to the vessel adjacent to it, and in a delayed phase it washes out. What's the significance? Is still debatable whether it is worth doing as a routine, which I don't think it will get the clinical utility as a routine investigation of choice. Again, this is a superior mediastinum retrosternal tissue just along the aortic arch, and that shows enhancement. So reported sensitivity in literature suggests 46 to 87%. No convincing advantage over MIBI and ultrasound, and the effective dose you've seen is 4.87%. It's just a comparison of PET CT looking at 18 FDG with methionine, and it shows sensitivity between these are only 7 patients, and it was long. Basically the papers reflect the age of the investigation, so most of the literature is from 90s, so it has grown and it has been overtaken by the MIBI and ultrasound. So the ranges are variable, but majority of them is in 90%. So this is a good paper by Williams et al. Looks at the comparison. It does a comparison of SPECT CT, SPECT, and planar imaging with single and dual phase MIBI parathyroid. And it looks at the sensitivity and specificity and clinical significance, and it compares the SPECT and delayed SPECT CT, compares the early SPECT CT with delayed planar, early SPECT CT with delayed SPECT, and early SPECT CT So it has got a quite range of variables looking at the SPECT and the planar and the SPECT only. So the range, if you look at the SPECT CT, is about 72%, and the specificity is between 99%. So it's quite significantly better looking at the early and early SPECT. So it's better to do a delayed so that you get better sensitivity and specificity in detection. Looking at the surgical history, Felix Mendel was the first person in 1925 performed the first successful parathyroidectomy in Vienna. Incision was 10 centimeters and exploration of all 4 parathyroid glands to find adenoma. It took about 1 to 2 hours of operating time. In Europe and now most of the countries, because it's the neck is the exposure site in Western countries, so the scar is the very limiting factor, and because of the cosmetic reasons, people want smaller scars, which is not seen without any abnormality and deformity of the skin. So they have now tried to do a minimum invasive surgery with nuclear medicine localization. When most cases of hyperparathyroidism are due to solitary adenoma, it makes no clinical sense to operate on all 4 glands unless absolutely indicated. Minimal invasive surgery, basically nuclear medicine directs them where the abnormality is, so they can do an endoscopic technique. Wound size is about 2.5, so it's gone significantly down from 10 to 2.5, and operating time is reduced to less than 25 minutes. As low as 15 minutes can be performed. Most frequent cause of unsuccessful parathyroidectomy is either there is an ectopic gland, undetected multiple gland disease, or supernumerary parathyroid gland. The surgery is, I said just now that it is directed by the exact localization, and this can be adopted by whatever modality you want to use and whatever phase of imaging you want to use. It depends on the site where you are working, where you have got SPECT CT or you are used to doing only planar imaging and doing 2-point times scan. So it's good enough as long as you are confident in what you are looking and what you are reporting and guiding the surgeons. But I think with the planar it becomes very difficult because they need the depth, they need to mark the site, and they need exact dimensions. So that can be shown only with SPECT CT. Otherwise with the planar imaging it's difficult to show the depth. You can only localize the site. So I think that's why SPECT CT is very important for localizing and directing the surgeons. Currently, E&M guidelines do not recommend routine use of the SPECT CT. Consensus only on the use of SPECT in ectopic adenomas or failed cases. We routinely use SPECT CT as our normal practice. A negative maybe scan is a predictor of those patients who are less likely to be cured. Parathyroid scintigraphy is a tool of utmost value for success of parathyroidectomy in an adenoma. Just looking at some cases, this is a 58-year-old female patient presented with hyperthyroidism and osteoporosis and was referred for localization study. Calcium was 2.7, slightly raised, and PTH was 14. So the scan shows focal uptake, and late scan basically retains the activity in the right inferior part of the right lower lobe of the thyroid, just above the sternoclavicular joint. And doing the SPECT CT, it nicely localizes in the superior mediastinum. Same patient and coronal projections. The ultrasound shows exactly the adenoma localizing in the exact site. Management: patient had minimal invasive parathyroidectomy, and histology confirmed the diagnosis. Second, prevascular anterior mediastinal mass 45-year-old lady, hypercalcemia, raised parathyroid hormone. Again, did a planar, did a SPECT, nicely localized the uptake. Where is it? It confirms that it's again in the superior mediastinum. Negative planar and positive SPECTs. Gentleman presented with hyperthyroidism. Calcium was 3, raised hyperparathyroid hormones. Weight was 185 kg, which exceeded the bed limit of 180 kg. Hence, the patient was scanned in the sitting position. So you don't see anything. Negative scan, but look at the size of the patient, and you've got artifact because this is a low dose CT. So with the fused images, you clearly demarcate the abnormal uptake towards the medial end of the clavicle. So it basically directs and guides the surgeon, especially in this patient where they would have traced the cause of hypercalcemia in the thyroid region. But localizing the nodule in the superior mediastinum, you can directly go into this laparoscopically or by minimal invasive surgery and take the nodule out. Management patient had minimal invasive parathyroidectomy, histology confirmed adenoma, and the postoperative calcium returned to normal. Ectopic adenoma, referred for localization, calcium raised, parathyroid hormone raised. Again, so shows heterogeneity with slight probably uptake in the isthmus, and delayed again some retention in the thyroid with slightly more retention in the midline, probably in the isthmic region. If you look at this, you would have said, oh, this is probably in the isthmus. It's very difficult to show exactly where the anatomical site would be. And this was an ectopic gland. That's the posterior between the tracheo-esophageal groove. So patient had successful surgery, confirmed adenoma on histology, and postoperative biochemical markers returned to normal. Parathyroid carcinoma, 45-year-old gentleman presented with hypercalcemia and raised hyperthyroidism, heterogeneous uptake on the planar early and delayed images. Did a SPECT, large mass involving the, and basically encasing the left lobe of the thyroid, displacing and compressing the trachea, and patient had resection of tumor and left thyroidectomy. Histology confirmed parathyroid carcinoma with capsular and lymphovascular invasion. Post-operative and follow-up in 6 months, there were normal biochemical markers. In conclusion, the introduction of SPECT CT has shown a clear improvement in identifying histologically positive and negative disease. This technique has proved to be more sensitive, specific, and accurate compared to conventional planar imaging. It is better at detecting parathyroid pathology localizing because of the superior anatomical localization of CT component. Overall SPECT CT result is less equivocal and finding clearly impact on surgical management by providing a roadmap for the surgeons. And we are keeping surgeons happy. Thank you very much.